And so I'm here to just give a stronger throw, I think, but I think it's clear now.
Could we start, sir?
I think we should start. We are just dot 5:30. Yes.
Okay, sir. So, very good evening, everyone. On behalf of IAIO, I extend a very warm welcome to all the delegates joining us for IAIO Expert Insights in Hemato-Oncology, scheduled for today, 23rd December, in virtual mode. We are delighted to have such a distinguished gathering of experts and participants for this focused academic deliberation aimed at advancing evidence based clinical practice in hemato-oncology. At the outset, it's my privilege to express our sincere gratitude to our program director, Dr. Tushar Pandey sir, a distinguished hemato-oncologist and director head, Raghav Institute of Hematology, Uttarakhand. As Dr. Pandey's academic leadership, clinical expertise, and commitment to hematology education have been instrumental in shaping today's scientific agenda, we truly appreciate his guidance in curating a highly relevant and clinically impactful program. Thank you, Dr. Pandey, for continued support and association with IAIO. Before we proceed further, it's my honor to briefly introduce our esteemed faculty for today's session. Dr. Pooja Prasad, Associate Professor, Department of Medical Oncology, Adult Hematolymphoid Unit, Homi Baba Cancer Hospital and Research Center, Punjab. Dr. Prasad brings extensive expertise in multiple myeloma and contemporary therapeutic strategies. And next are Dr. Nabajit Malik, Associate Professor, Department of Hematology from PGIMER Chandigarh. As respected academician and clinician, Dr. Malik will be sharing insights on advanced flow psychometry and MRD assessment. And next, our case presenter and moderator of the day, Dr. Saudamini Mahapatra, Assistant Professor from IMS and Some Hospital, Bhubaneswar. Dr. Mahapatra will be the presenter for today's complex myeloma case discussion. And coming to our panelists, Dr. Satrupa Mahapatra, Consultant Hemato-Oncology and Bone Marrow Transplantation, Bagchi Sri Shankara Cancer Center and Research Institute from Bhubaneswar. She brings valuable clinical experience in transplant and advanced hematological malignancies. Dr. Nakul Dilip Tikare, Consultant Hematologist, Manipal Hospital, Goa. Dr. Tikare contributes strong expertise in clinical hematology and real world practices and challenges. And it's indeed a special privilege to highlight Dr. Reena Nair ma'am, one of the senior most experts on today's panel. Dr. Reena Nair is a senior consultant, clinical hematology, and head of medical oncology at Tata Medical Center, Kolkata. She is widely respected for her leadership in clinical hematology, her academic contributions, and her vast experience in managing complex myeloma cases. Her insights, especially in navigating therapeutic dilemmas and MRD driven decision making, will add immense value to today's case discussion. We are honored to have her with us as a key panelist of this session. With this, we shall formally commence the scientific proceedings. I now request our program director, Dr. Tushar Pandey sir, to kindly take over the session and lead us through the introduction and context setting of today's program. Over to you, sir, please.
Thank you very much. So, very good evening to everyone present in the session. Now, multiple myeloma is one of the commonest hemato-oncological malignancies that we see day in, day out in our hematology and hemato-oncology practice. It is the dawn of a great time when we see the great, new innovative therapies developing when it comes to the management of multiple myeloma, from a triple drug regimen to a quadruple regimen. Now we also have bispecific antibodies. We have all the teclistamab, talquetamab, and various other combinations available. And very much research is going on in multiple myeloma with updates coming every moment hereof. Recently in ASH 2025, there was a very good paper as well with the combination of daratumumab and teclistamab for relapsed myeloma with very good response rates. So it is very important to stay updated for everyone, be it the DM residents, be it our fellow colleagues, and it's very important to get enlightened by our gurus and teachers who have taught us as well. So it's a very good platform, and we have designed it to ensure that everyone benefits in one way or the other. So session one is based upon all the updates and ideal management when it comes to multiple myeloma, which will be headed by Dr. Pooja ma'am, followed by a wonderful session by Dr. Nabajit Malik sir, who will be telling us about the basics of flow cytometry, how important it is, how it's used in both diagnostic as well as for response assessment and in clinical trial studies with the use of MRDs and its application in the clinical practice. Followed by session 3 will be Dr. Sadamni, who will be taking us with her own complex case of myeloma, and our expert panelists will be enlightening us with their experience and how they would approach in this case. So I welcome everyone again. I thank Team IAIO. And with that, I hand over to Dr. Pooja to please start with session 1. Ma'am, all over to you.
Okay. Thank you, Dr. Tushar and IAIO for this opportunity. So I will just share my slides. Okay, so my slides are visible.
Yes, clear.
Yes, they are visible.
So good evening, everyone. So we will be talking about some therapeutic strategies and emerging evidence in multiple myeloma. So I will be covering, just a sec, an overview of the disease biology, diagnosis, and risk stratification of myeloma. We will review the current landscape of myeloma therapy and understand the evidence for these contemporary regimens that are in place, and also highlight emerging treatments and future directions. So just a brief overview of the disease. We know that myeloma is a neoplastic plasma cell disorder characterized by clonal proliferation of malignant plasma cells in the bone marrow microenvironment. There is production of monoclonal protein in blood or urine, and there is associated organ dysfunction. So myeloma is at present the second most common blood cancer, and India is ranked third globally in new cases. And we know that the patient number is increasing exponentially. The median age at diagnosis historically has been in 60 to 70 years age. But we know that in India, we are seeing patients at least a decade younger presenting and being diagnosed with myeloma. We have patients in our practice who are coming in the late 40s and are being diagnosed with myeloma. So this disease has serious complications affecting the health function and quality of life. Though treatment has advanced considerably over the past 10 years, as we'll see in the further slides, still myeloma remains incurable. Patients of myeloma present with complaints due to anemia, thrombocytopenia, renal dysfunction, hypercalcemia, bone pains, bone fractures, neuropathy, cord compression. So, diagnostic workup includes investigations of CBC to highlight the anemia, biochemical parameters to look for renal dysfunction, hypercalcemia, total protein, and AG reversal. Myeloma panel, which includes serum protein electrophoresis to quantify the M spike, immunofixation electrophoresis to characterize the monoclonal protein, free light chain assay to assess the disease burden, beta 2 microglobulin to assess for risk stratification. Imaging can be done either through PET scan, low dose whole body CT, a skeletal survey. Bone marrow examination for the plasma cells, clonality assessed by flow cytometry, and cytogenetics and FISH testing for genetic abnormalities. So, International Myeloma Working Group has given the diagnostic criteria for myeloma to be defined as clonal bone marrow plasma cells more than equal to 10% or a biopsy proven plasmacytoma with any one or more of the following myeloma defining events, which is given by a mnemonic SLIM crab. So crab was the traditional markers of hypercalcemia, renal insufficiency with creatinine more than 2, anemia with hemoglobin less than 10, or more than equal to 1 osteolytic lesions on skeletal imaging. And there are certain other biomarkers which were found to be associated with near inevitable progression to end organ damage. So, a presence of more than 60% clonal bone marrow plasma cells, or a light chain ratio of more than 100, or even one focal lesion on MRI. So, after diagnosing myeloma, we need to stratify myeloma. So, the staging and prognosis of myeloma has evolved over the years from Dury-Salmon staging to international staging system, which incorporated beta 2 microglobulin and albumin levels. Then came the era of revised ISS staging, which incorporated the chromosomal abnormalities. So, a standard risk a cytogenic abnormality is absence of any high risk chromosomal abnormality, and high risk includes the presence of deletion 17p, translocation 414, or translocation 1416. This staging is very important as it tells us about the overall survival and prognosis of the disease, with stage 1 patients having a 5-year OS of up to 80%, and by the time it comes to stage 3, the overall survival goes down to 40%. Many other biological factors, genetic factors have been identified, like the presence of extramedullary disease, high plasma cell S phase, high LDH, and other genetic abnormalities like M-SMART, which has been given by the Mayo Clinic, has identified high-risk cytogenetic abnormalities like deletion 17p, TP53 mutation, biallelic deletion 1p, gain or amplification of 1q or deletion of 1p, beta 2 microglobulin more than 5.5, a primary plasma cell leukemia, or a newly diagnosed myeloma with extramedullary disease. All these are characteristic of a high risk myeloma, which may be resistant to further therapy, and it can also have a bearing on the treatment. So, multiple myeloma patients usually progress from pre-malignant stage of MGUS, which is a monoclonal gammopathy of uncertain significance, and smoldering myeloma to come on to active myeloma. So, in myeloma, we know that this disease, the myeloma disease trajectory, it is characterized by malignant transformation of the plasma cells and serial cycles of response, remission, and relapse. And with each line of therapy and with each remission, the duration of remission and depth of response will decrease with each line of therapy. So for that, it's always said that myeloma treatment is like a marathon. It's not a sprint. It's a lifelong affair, and it is highly critical that we use effective treatment at the frontline setting. Patients should receive potent combination therapies which can eradicate a majority of subclones and give us deep responses, prolonged remission, and potentially which can be curative. We also know that therapy-induced remission is more likely in patients with newly diagnosed myeloma than in the relapsed setting. So it is essential that it is critical that we use good therapy in the initial setting. So the treatment landscape of myeloma has evolved substantially, especially in the past 2 decades. We have seen newer molecules, new approvals coming every year. So with the advent of bortezomib and lenalidomide, doublet therapy had become a standard of care in the early 2000s. Then triplet therapy was a standard by 2015. Then came the approval of monoclonal antibody like daratumumab, and till 10 years back, we were giving quadruplets to all patients. Then further new therapies, like in the past 3 years, we have seen approval of bispecifics, of CAR T cells, and newer drugs are still always in the pipeline. So this is just a table summarizing the treatment options which are available for treatment of multiple myeloma. These are different classes of drugs, like we have immunomodulatory drugs, thalidomide, lenalidomide, pomalidomide, proteasome inhibitors, bortezomib, carfilzomib, ixazomib. Steroids have been the traditional backbone. Monoclonal antibodies like daratumumab has become a general practice now. Isatuximab, elotuzumab. Then standard chemotherapy alkylating drugs are also used in certain cases. Then the therapy of myeloma, as we know, should always incorporate supportive care, like bone modifying agents are essential for treatment for myeloma, which have a bone modifying effect as well as an anti-myeloma effect. The prophylaxis for HSV and varicella zoster, prophylaxis for PCP, and even antibacterial prophylaxis with levofloxacin has been recommended for the first 2 months of a patient started on induction. Palliative care, especially targeting pain relief and other control of other systems, has to be integrated at diagnosis and continued throughout. So the traditional backbone for myeloma therapy has been a triplet induction. That means a combination of 3 drugs, a proteasome inhibitor like bortezomib, immunomodulatory drug like lenalidomide, and steroid. This has been the frontline standard, along with autologous stem cell transplant in eligible patients and maintenance therapy to prolong the remission. After the introduction of daratumumab in 2010, the combination of daratumumab to this triplet therapy was shown to give us deeper responses and higher MRD negativity also. And in some cohorts, we have seen patients approaching functional cure. So the evidence for this came from the Perseus 3 trial. So adding daratumumab to VRD was found to have a MRD negativity at 24 months, which was nearly doubled with in comparison to only VRD. So it was 50% in the DARA group and 30% in the VRD group. And the survival benefit was also seen. So frontline quadruplet options for transplant eligible patients was cemented by these two landmark trials, Cassiopeia and Griffin. So just a brief overview of the Cassiopeia trial. So in this, transplant eligible newly diagnosed myeloma patients were randomized into 2 cohorts. The first cohort received the standard VTD, which is bortezomib, thalidomide, and dexamethasone every 28-day cycle. And the other cohort received daratumumab in addition to VTD. Daratumumab was given at the standard dosing that we know, 16 milligram per kg weekly for the first 2 cycles, then twice weekly for once in 2 weeks for the next 2 cycles. So after 4 cycles of this induction therapy, the patients underwent autologous stem cell transplant, followed by consolidation with same therapy for 2 further cycles. After this, there was a part 2 of this study in which the patients were randomized further for maintenance as daratumumab monotherapy received in 1 cohort and observation for 2 years in the second cohort. And the primary endpoint was stringent CR, secondary endpoints was PFS and OS. So Cassiopeia 2 documented that maintenance therapy with daratumumab, it reduced the risk of progression by 51% as compared to the observation group. And the second graph, which is a Kaplan-Meier curve, it is showing 4 curves. So there were 4 randomizations. One group was VTD followed by observation. Second was DARA VTD with observation. Third was VTD followed by DARA maintenance. And the fourth was DARA VTD with DARA maintenance. And the longest PFS was observed in this cohort of patients who received daratumumab in induction consolidation and then also received DARA maintenance. This was at a median follow-up of nearly 6 years. In this same subgroup, there was overall MRD negativity was also highest for this group, which was around 60%. And this is also at a median follow-up of nearly 7 years. When they looked at the most common adverse events, there were no grade 5 toxicity in the DARA group. There were just less than 1% grade 4 toxicity, which was not fatal. Grade 1 or 2 toxicity was commonly seen in the DARA group, which was mainly infections and hypogammaglobulinemia, which were conservatively managed. So similarly, the Griffin study studied the addition of daratumumab to VRD backbone. In this also, it was DARA VRD 4 cycles induction followed by transplant, consolidation 2 cycles with same therapy, and maintenance randomized into DARA LEN and LEN maintenance only. So in this also it was found that MRD negativity was higher in the group which received DARA with VRD, and this negativity deepened over time until the end of study maintenance. So with these 2 studies, daratumumab became a standard of care. So in addition to Lendex, it became the new standard of care for transplant ineligible patients, and in combination with VRD or VTD, it became the new standard of care for transplant eligible patients. Now, autologous stem cell transplant, as we have seen, it over the last 3 decades, it has been a very primary therapeutic modality. So with the triplet induction also, there is prolonged median progression-free survival, increased median progression-free survival with transplant, but OS rates have never been found to have a bearing, the transplant having a bearing on the overall survival. There is increased PFS, there is increased MRD negativity, and mostly there is increased rate of adverse events, but they are all tolerable and they do affect the quality of life for the first 3 or 4 months, but after that it does improve through maintenance. And with the advent of quadruplet, Cassiopeia has studied quadruplet therapy with transplant, and that has also shown that with addition of daratumumab, the depth of response and progression-free survival increases before and after patients receive transplant. So autologous stem cell transplant, as we know in myeloma, has steps which includes mobilizing the stem cells from bone marrow into peripheral blood by GCSF and Plerexa for mobilization. Then stem cells are collected through apheresis. They are cryopreserved. Patient is given conditioning regimen with high dose melphalan at 200 milligram per meter square. And then the third stem cells are infused back, and then we wait for engraftment. So for newly diagnosed myeloma, the Mayo group every year takes out treatment algorithms, and this is the latest algorithm which has come right after ASH 25. And Dr. Shaji has divided newly diagnosed myeloma into standard risk and high risk. So for standard risk, quadruplets are the standard induction, and they should be offered an early transplant if they are eligible after 4 cycles, followed by a LEN maintenance or LEN plus DARA maintenance. For patients who are high risk, they should receive quadruplet followed by transplant and doublet maintenance. So when we know that these patients will eventually relapse. So for relapsed myeloma, treatment paradigms have been evolving. The therapy choice will depend on the prior line of therapy, what was the depth and duration of response from the previous therapy, what is the present patient performance status, and we have several novel options which are now available to us. And most of them are targeting BCMA. So what is BCMA? It is B cell maturation antigen. It is a member of the TNF superfamily, which is expressed preferentially by mature lymphocytes. There is minimal expression in the stem cells. And it has been found that overexpression and activation of BCMA is associated with progression in myeloma. So we have BCMA as central target in used in ADCs, that is antibody drug conjugate belantamab. Then we have bispecific antibodies which will engage T cells to the BCMA on myeloma cells. So we have teclistamab in that. And then we have CAR T cell therapy. So just a figure showing the myeloma cell expressing the BCMA. These are the bispecific engager and bispecific antibodies. So they have they will connect the CD3 on T cell to the BCMA on the myeloma cell and cause a direct lysis. And then there are CAR T cell. So in CAR T cell, the leukapheresis is done, T cells are collected, it is sent to a processing or manufacturing lab where these T cells are transduced with a viral vector with the BCMA CAR, and then this CAR is expanded, and then these CAR is only infused back to the patient after lymphodepleting therapy. So coming to the BCMA targeted CAR T cell therapies, now they have reshaped treatment for patients with relapsed refractory myeloma. And we have two CAR T products. We have Cilta-cel and ID-cell. So Cilta-cel approval came after CARTITUDE-1 study. Just summarizing this data. So they tested Cilta-cel for this is the study design. This was a phase 1-2 study of patients with relapsed refractory myeloma who were mostly triple class refractory in majority patients and penta refractory in 50% patients. And the Cilta-cel was given the disease biology also had extramedullary plasmacytomas. There were high-risk cytogenetics in 1/3 of patients, and the bone marrow plasma cell percentage was also more than 60% in 1/5 of patient. So in this phase 1 or 2 study with relapsed refractory myeloma at a median follow-up of 2 years, an overall response rate of nearly 97.9% was achieved, with 82% get in stringent CR and 94% in VGPR. And these are patients who are heavily pretreated, who have high-risk cytogenetics, who are triple class refractory, who have extramedullary disease, and at a median follow-up of 27 months, these results are quite exceptional. So this was the summary for that. This is it, yeah. So an overall response rate of 98%, a stringent CR of 80%, and a median progression-free survival of 35 months. There were toxicity, CRS, as well as some delayed neurotoxicity was also reported. The second CAR T product is ID-cell, which has come after approval through the KARMA phase 2 study, in which again, it was tested in heavily pretreated relapsed refractory myeloma patients, and an overall response rate of 73% with CR of 33% has been seen at a median follow-up of 25 months. CRNs and cytopenias, hypogammaglobulinemias, need for IVIG injection is a common part of CAR T therapy. We can see in this table summarizing the KARMA phase 2 study that an overall response rate of 81% was seen, with a median duration of response of 11 months and a median progression-free survival of 12 months. The CRS rates of any grade were seen in nearly 84% patients, and there was need for usage of tocilizumab and steroids also. So for our setting, we need to see the toxicity profile of CAR T with neuropathy, ICANS, management of infections, hypogammaglobulinemias, ocular events. We need to select the patients. And of course, there is an issue of access of these therapy and cost barrier for our patients. So the CAR T outcomes are summarized in this slide. So CAR T therapies on a meta-analysis, they have shown that they produce higher response rates and higher response depths as compared to bispecifics for relapsed refractory myeloma. An ORR of 84% and a CR rate of nearly 55% is seen for CAR T. there is higher incidence of CRS, there is higher incidence of neurotoxic events, but there is significant survival benefit. So if these acute toxicities can be managed properly, they require skilled management, we can move ahead with CAR T. Coming to FDA approved bispecifics, there are 4 bispecifics which have got approval, of which teclistamab is the first in class of the shelf T cell redirecting bispecific, which redirects the CD3 positive T cells to mediate T cell activation, cytokine induction, and subsequent lysis of the BCMA expressing myeloma cells through secretion of perforin and granzymes. So, teclistamab has got approval and it has been studied through Majestic 1 trial, in which teclistamab was given for heavily pretreated relapsed refractory myeloma patients, and an ORR of 60% was seen, the CR rate of up to 45%, and the median progression-free survival of 11.3 months. But the more exciting data which has recently come and which was presented in ASH 2025 was a combination of teclistamab with daratumumab, which was studied in the Majestic 3 study. So these are graphs which were shown in, which are presented in the ASH from the abstract. So we can see that a combination of teclistamab and daratumumab showed substantial benefit versus all the other standard regimens. There is improved OS, there is improved PFS, there was higher CR, and there was MRD negativity. We can see at 36-month progression-free survival, Tec Dara was at 83% at a median follow-up of 34 months. So there was improved PFS and there was a plateau reached after 3 months, and more than 90% of these patients were progression free at 6 months, and this benefit was sustained at 3 years. It also significantly improved the overall survival when compared with Dara-Pom Dex, and some patients also received Dara-Boti Dex, and 83% of patients were alive at 3 years. So comparing CAR T and bispecifics, so we have seen with these two studies that CAR T, the depth of response is very high. There are frequent stringent CRs and MRD negativity is achieved. Bispecifics are also giving us high depth of response, but it is less deep. The PFS is longer for CAR T. Administration for CAR T is also a single infusion, whereas for bispecific, it requires repeated dosing. However, the side effects of CRS and ICANS are high. There is high risk and severities can also be high. It requires a manufacturing time. At that time we need to give some bridging therapy, and we use bispecifics as bridging therapy before CAR T, which can enhance the T cell expansion. And of course, cost is still prohibitive for CAR T as well as bispecifics. So the treatment algorithm after ASH 2025 and all the data that has been presented. So for relapsed myeloma, who are not the patients who are not refractory to any anti-CD38 and those who are refractory. The ones who are not refractory to anti-CD38, Tec, Dara, or the CAR T can be given. If nothing is possible, then a standard triplet may be given. For patients who have already received Dara and who are refractory to Dara, for them, Cilta-cel or ID-cell CAR T can be given. So, other drugs like venetoclax, if there is an 11-14 translocation present, talquetamab or combination of talquetamab, which is still under evaluation, then selinexor-based therapy, or we go back to bendamustine-based regimens or combination chemotherapy. So with all this, so there are other studies which are in the pipeline. So there is long-term follow-up data from the Majestic 1 and 2 study which is available, and we have seen that with 2-year at 2-year median follow-up, responses to teclistamab are continue to be quite deep with CR rates of up to 50% and durable responses, and some patients have been switched from weekly to monthly dosing as well. There is a study on talquetamab, which is again a bispecific with CD3 and G protein coupled receptor. So the Monumental 1 study has studied talquetamab in heavily pretreated patients, and it is still under evaluation. Then there is a combination regimens of talquetamab with teclistamab which are being studied. So the redirect TT1 trial is assessing that, and it has shown some high responses. Cartitude 4 continues to demonstrate the superior efficacy of siltacel for as a standard in comparison with standard of care regimens for relapsed refractory myeloma. And the PFS benefit, the rapid deep response is continuing. So it is really highlighting uh, to become a good therapeutic option for patients with multiply relapsed refractory myeloma. But for us, at present, transplant still matters. We know that high dose therapy with melphalan followed by transplant remains a backbone. It continues to provide additional deepening of response, continues to provide longer PFS and improved overall outcomes. Quadruplet induction with transplant is achieving significantly higher stringent CR rates and higher MRD negative rates. And has been no issue with stem cell collection. It still remains feasible. It still remains effective. There are trials evaluating MRD-based decision making for quadruplet with transplant, which is under study. So for us, for our patients, transplant is still more feasible in the context of knowing about the toxicity, managing the toxicity, and the cost efficacy. With all this exciting data, the main question still remains whether cure is finally achievable in multiple myeloma or not. This question has come every year, where after every new exciting therapy, we think that yes, we will finally achieve a cure, but we are still chasing a moving target. And this is a very nice editorial which has just been published last week after the exciting data of Cartitude 1, which was presented in ASH 25. And so Cartitude 1 at a long-term follow-up, there is a median follow-up of over 5 years. It has shown an overall survival of 60 months with a sustained response, durable PFS, and in nearly 1/3 patients who were treated with a single infusion of siltacel without any maintenance therapy. So this, and without any no new long-term safety profile toxicity. So this is reinforcing the concept of functional cure, at least for a selected group of patients. So let's see what the future has in store for myeloma and our patients. And this is just a picture from our patient awareness meets, which we hold every year in the month of March. And we interact with our patients of multiple myeloma. And there is a long way to still go. Yeah, thank you.
Right. Thank you, ma'am. It was such an enlightening session, and we have lots of treatment options now, and we have seen the scientific data that justifies their use and when to place them. Thank you so much, ma'am. It was highly enriching session. Now, without further ado, we'd like to move to our next session, where Dr. Navjit Malik will be leading us, and the session is on flow cytometry and its application in multiple myeloma while during diagnosis, as well as during our response assessments and planning of therapy with the MRDs. So I welcome you, Navjit sir, and I hand over the stars to you. Please, sir, continue.
Thank you.
Thank you. Let's just start by setting the screen here now. Right. I hope my screen is visible at the moment.
Yes, it's visible, sir.
Right, great. So at the outset, let me thank Dr. Tushar and this group for inviting me for this talk. And after this wonderful talk on all the advancements in therapeutics of multiple myeloma, let's take a little breather, and let's look at the flow cytometrist perfect perspective of multiple myeloma. So the first question, is there a role of flow cytometry in plasma cell neoplasms? And if it is, then what is that? So let's see. So the basically first role would be during diagnostic workup. So do we require flow cytometry for the diagnosis of multiple myeloma? This is a question that has been asked and that has been debated for a very long time. And we'll try and come to that. This is still questionable. There are some people who say yes, there are some people who say no. Let's see. Then the second is the assessment of minimal or measurable residual disease, that is the MRD monitoring. There's no doubt about this here at all, right? The prognostic significance of MRD in myeloma is well known and no problems here at all. The third role of flow cytometry in plasma cells neoplasms is the evaluation of circulating tumor plasma cells. Now, this is more in the research mode, and we'll talk about it a bit, but my hunch is that in the coming years, this might actually be a game changer in the field of flow cytometry in relation to plasma cell neoplasms, right? So looking at the diagnostic criteria, which has been wonderfully covered by Dr. Pooja in her talk there, we saw that what we require are two of these criteria. The first, of course, being the presence of more than 10% clonal bone marrow plasma cells, along with a biopsy-proven plasmacytoma, and one of the myeloma defining events, which is basically either a crab or a slim crab. Right. So in this diagnostic criteria, where does flow cytometry fit in? Do we require flow cytometry at all? So if we take a closer look, we see that yes, we do want to say that these bone marrow plasma cells, which are more than 10% or more than equal to 60%, they have to be clonal. Now, flow cytometry is a wonderful method of measuring the clonality or assessing the clonality of these plasma cells. But is it the only methodology? All of us are doing serum protein electrophoresis in myelomas, and the M band that we talk about is basically a monoclonal band. So that is also a marker of clonality. So there's a doubt here whether we actually require myeloma for the diagnosis or not. Let's go ahead and let's look at this paper from Blood Cancer Journal in 2017, where they say that they have two kinds of roles in of flow cytometry in multiple myeloma diagnosis. One is in resolving the differential diagnosis, where between conditions where there is prominent but reactive and benign plasmacytosis with neoplastic plasma cell disorders. Now, this is a very, very important presentation where flow cytometry really helps us. So we've had conditions, and not just benign conditions, but other neoplasms as well, where we have a lot of reactive plasmacytosis. I'm not showing the case here, but we recently had a case of a patient, elderly male, who presented with severe anemia and came to us, and the peripheral blood had nearly 30% plasma cells. The bone marrow had nearly 40% plasma cells. So looking at the morphology, we were ready to sign it out as a plasma cell leukemia. But when we did the flow cytometry, all those plasma cells came out to be polyclonal, not monoclonal. And when we further looked at the T cells in that case, we saw that there was some TFH, or the follicular T helper cell markers, and it actually turned out to be a case of AITL. So yes, in these conditions, flow cytometry becomes a big help. Then there are some lymphomas which have a prominent plasmacytic differentiation. Very common of these, of course, is the LPL and marginal zone lymphomas. And of course, also the rare IgM myeloma cases, we can do flow cytometry to confirm that these IgM producing cells are actually plasma cells immunophenotypically as well. The other is providing prognostic information, but that is absolutely not used very widely these days because we have so many other prognostic indicators. And what are these prognostic markers on flow cytometry? One of them is the proportion or clonal plasma cells in the bone marrow. So in MGUS or smoldering myeloma, if the plasma cell, out of the total plasma cells, if the tumor plasma cells are less than 95%, they are called as the MGUS-like phenotype. And if they're more than 95%, they're called as the myeloma-like phenotype. Now, MGUS and smoldering myelomas having a myeloma-like phenotype, that is more than 95% of all plasma cells being tumor plasma cells, they progress to a multiple myeloma much quicker than the MGUS, the ones which have an MGUS-like phenotype, right? And also in symptomatic multiple myelomas, if there are more than 5% normal plasma cells, which is an MGUS-like signature, they have a better PFS. You'll see that the references I'm using are old, 2007, 2013. So yeah, these are not really used much. Of course, marker-based prognostication also, again, a paper from 2008, CD117 having a favorable prognosis, and 828, 1981, again, having a bad prognosis. Not really used much. Okay, so how do we gate the plasma cells? So what is the gating strategy that is most commonly used in flow cytometry? The three markers that are very, very commonly used are CD138, 38, and CD45 along with scatter properties. And this is how we go about it. We'll talk about it in a little detail in the next slides. And do we use any other marker for gating plasma cells? We said that we use CD38 and 138. Are there any issues with 38 and 138? Not really. 138 and CD38 are really brightly expressed in most plasma cells. And unless you have a therapy which is against one of these antibodies, you usually can use these plasma cells, these markers, CD38 and 138, for gating out the plasma cells very nicely. However, as a caution, I must tell you that there are some myelomas which at diagnosis can have a great downregulation of CD38, and there the gating can be difficult using the marker of 38 and 138, right? So otherwise, these are very good markers for gating plasma cells. But can other markers also be used? There's a 2016 paper which has studied multiple other markers like CD150, 229, 352, 319, 48, 272, 184, 86, and 200. And they found that 229, CD319, 48, and 272 were the best of the new surface antigens, which can also be used in addition to 38 and 138. We have our experience with both CD229 and CD319. They are great markers and are expressed in most plasma cells, both normal and abnormal. And nowadays, in cases which are receiving daratumumab therapy, we use CD319 as the ancillary gating marker. Right. What are the markers for analysis of plasma cells? Various markers that we have to use, an array of markers for analysis of the plasma cells. We gate them using 38 and 138. And then we look at CD19, CD45, 27, 81. These are all present in the normal plasma cells. And 56, 200, 117, 28, and 20, which can be downregulated or negative or weakly expressed in normal plasma cells. On the other hand, these markers are nicely expressed or overexpressed in the abnormal plasma cells. And 19, 45, 27, and 81 are downregulated in the abnormal plasma cells. Right. CD38 and 138, as we said, are used for gating of this abnormal plasma, the entire plasma cell population. However, please remember that CD38 can be dimmer in abnormal plasma cells and CD138 can be brighter in the abnormal plasma cells. So, not just in gating, these two markers can sometimes also be used in differentiating the normal plasma cells from the abnormal plasma cells, right? Now, all cases won't have all these marker profiles together. Some cases might only have a downregulation of CD19 and an upregulation of CD56, or say a downregulation of 27 and an upregulation of 117. So an array of all these markers is required. So a big panel, including all of these markers, is required to properly differentiate your normal plasma cells from an abnormal plasma cell. And in addition to that, we should also always remember that all these cell markers that we're calling as markers of abnormal plasma cells can also be present in a proportion of normal plasma cells. For example, 19 negativity, as we are saying, as is marker of abnormal plasma cells, but always a proportion of normal plasma cells will show an absence of CD19. Similarly, a proportion of normal plasma cells will show an upregulation of CD56. Right? So that's why we need to use a whole array of all these markers and confirm using kappa and lambda cytoplasmic chain restriction. Out of all these, it is only CD117 that is nearly sacrosanct. It is never really overexpressed in the normal plasma cells, while all the others can be. The tube that we use in PGI, it's a single tube 10 color panel. That is because we have a 10 color flow cytometer in our institute, where we use cytoplasmic kappa and lambda for the clonality assessment, and 38 and 138 for gating of this plasma cell, and 45, 27, 117, 81, 56, and 19 for differentiating normal plasma cells from the abnormal ones. Right. So let's look at how we gate these plasma cells. We gate them using, these are the four initial plots that is used for most flow cytometry based gating of the hematological malignancies. Initially, we take continuous events. We remove our doublets. We take only the viable cells and see the CD45 versus side scatter plot. And then we get a big region of CD38 and 138 bright cells, which include the plasma cells. We always take it as a broad gate and include some dim 38 and 138 cells also, just in case some of our plasma cells are down-regulating CD38 or 138. We purify this plasma cell region by using the gate of CD38 and versus 45, where we take only the cells which are 38 bright and 45 dimmer. We remove the cells which are 38 dim and 45 bright, because these are very, very unlikely to be plasma cells. And then we use a scatter marker, side scatter, and from these broad plasma cells, we take only those cells which are 38 bright and have a low to intermediate side scatter. Right. So after we have gated these plasma cells here, we now look at a panel of markers to differentiate the normal from the abnormal plasma cells. And on all of these, we see there are two kind of populations. And you can get wherever these two populations are being separated nicely, we can gate them. For example, here we can see this nice population, which is positive for 27 and 81, which are markers for normal plasma cells. And then there's another population which is nicely negative for 27 and 81, so most likely abnormal plasma cells. So we gate them separately. We call these black ones the normal plasma cells and the red ones the tumor or the abnormal plasma cells. And we see that they are fitting nicely in the other plots as well. These red ones are also 19 dim, 45 dim, whereas the normal plasma cells are 45 brighter and 19 brighter, and so on and so forth. They are also, the abnormal plasma cells are 56 bright positive, whereas the normal plasma cells are 56 negative and 27 positive. The red ones, abnormal ones, are also 117 positive and 19 negative, whereas these normal plasma cells are 19 positive. And the proof of the pudding will always be in the kappa and lambda staining, where we have to do a cytoplasmic kappa and lambda staining, because our plasma cells have a cytoplasmic kappa and lambda expression. They don't have kappa and lambda light chains on their surface, right? So these normal plasma cells are dividing nicely into kappa and lambda, whereas these clonal plasma cells, the tumor plasma cells, are, as we see here, cytoplasmic lambda restricted, right? These are also, as we discussed, the red ones, the abnormal ones, are also CD38 slightly dimmer than these bright normal CD38 bright positive normal plasma cells. We can see them, look at them in other profiles also, like in the 38 versus 45, we can see that these are abnormal ones are 38 dimmer and 45 also dimmer. They have a big high forward scatter, meaning that these are large cells compared to these cells which are the lymphocytes. Great. So now let's come to the other issue that we face during diagnosis. So that is the percentage of plasma cells. So now the percentage of plasma cells is mostly lower than that which is noted in morphology smears. So most of us who have done bone marrow aspiration and biopsy, we know that while doing the aspiration, we get a lot of hemodilution, right? Because the bone is so fragile in these multiple myeloma patients. And so why do we get lower percentage of plasma cells on the flow cytometry? That is because the most probable explanation is that the tumor plasma cells are associated with the lipid-enriched bone marrow spicules in the morphology slides, whereas the slides that the sample when they take for flow cytometry, they are the lipid-depleted liquid bone marrow, and here the plasma cell percentage will always be less. So please note that when we are doing a flow cytometry, when we are looking at the percentage of the plasma cells, the gold standard is always morphology, and we should not look at flow cytometry to count the percentage of plasma cells. We should only look at it to see the proportion of the normal versus abnormal plasma cells. Right. So let me present some cases to establish that whether it is actually required to do a bone marrow at diagnosis or not. So we have a 65-year-old female who was referred with hypercalcemia and anemia and bone pains. There was no renal abnormalities. There was no lymphadenopathy or hypersplenomegaly either. And when we looked at the bone marrow aspirate, we are seeing all these large cells. You can see all these abnormal large cells making 43% of the bone marrow cells. These cells are huge. Some of them are very, very nucleolated. They are looking blast-like. They can be monocytoid blasts. I don't know. Some of them also look adherent to each other. Can they be non-metabolic tumors? They are looking very abnormal. Definitely not like plasma cells. Here also we can see the imprint smears. Also these cells in the imprint touch smears, some of them are also looking like erythroids maybe. Yeah. Even in the bone marrow biopsy, you can see this area which is infiltrated. When you go closer, all these large cells, nucleolated cells, are large, bizarre abnormal cells. And when we do a flow cytometry, we don't see that is anything there in the CD45 dim region. So unlikely for them to be blasts. Because the patient had hypercalcemia and bone pains, we did a plasma cell tube, and we see that there are some cells in the plasma cell region. We get out the plasma cells. The plasma cells in the 27 versus 56 plot show three populations. We gave the three populations separately. One is 56 negative and 27 negative. One is 56 positive and 27 negative. And the third is 27 positive and 56 negative. We put other markers, and we see that both these populations, the ones which is 56 positive and 56 negative, but 27 negative, they're all kappa restricted. So this is actually abnormal clonal plasma cells. And this, what we had here was a plasmablastic myeloma. So very, very bizarre morphology. And in such cases, flow cytometry really helps to make the diagnosis of a multiple myeloma. Let's go to another case. We have a 68-year-old lady who had bone pains. The PET scan showed osteolytic lesions in the entire axial and appendicular skeleton, and the IFE showed an IgG lambda. But when we looked at the bone marrow aspirate, all we could see were these cells. All these look like lymphocytes. You can call them that they're plasmacytoid lymphocytes, but they're all looking like lymphocytes. Here is a high power view. But when we did a flow cytometry, what we found was that there were large number of these 38 and 138 bright cells. They were nicely lambda positive, 81 bright, 27 negative, so abnormal plasma cells. We did a FISH and we found that this was 11-14 translocated. So this was basically a 11-14 translocated multiple myeloma, which have a very lymphoplasmacytoid morphology. So whenever you have a myeloma which has a lymphoplasmacytoid morphology, a lot of them are enriched with the translocation 11-14. Okay, another case, a 62-year-old male had back pain, MRI showed lytic lesion in vertebra and an MBAT was present. Again, we went ahead and did flow cytometry. We enriched the plasma cell region. We gated our plasma cells. And here we can see that there are probably two populations of plasma cells already here. So when we gate them in different plots, we can see that there is one population here and another population here, right? Even in this 56 versus 27 plot, we can see that there are two populations. And we gate them, one of them being 56 bright and 200 bright, the other being 56 negative and 200 negative. So we call them target 1 and target 2 populations. And we see that this target 1, which is 56 and 200 bright, are also 38 dimmer, right? So these are most likely abnormal plasma cells, and the blue ones are most likely going to be normal plasma cells, right? So then when we look at the blue population separately, the ones which we think are normal plasma cells, we also see a separate subpopulation happening here. We are showing dimmer CD45. We gate this population as a suspect population separately. And among these, we see something that is bright for CD117 and 28. And we get this population separately also. Now let's look at the clonality. So this population, which is coming out of the apparently normal plasma cell population, is actually lambda restricted. The other already, the one which we saw was 56 bright, 27 negative, is kappa restricted. And the blue population, remaining blue population, is actually dividing nicely into kappa and lambda. So we have normal plasma cells. We have a big chunk of this kappa restricted plasma cells, and we have a very tiny population of a lambda restricted plasma cells. So what we have here is basically two clones of plasma cells here. And the second clone is very tiny, which we would definitely have missed on the serum protein electrophoresis. And again, this highlights the role of flow cytometry in diagnosing these biclonal plasma cells. Right. So I think I might have convinced you that we do require doing flow cytometry at baseline for these plasma neoplasms. So we move on to the next role, that is in the circulating tumor plasma cells. So circulating tumor plasma cells is a subset of tumor cells that that exit from the bone marrow into the peripheral blood as a result of the dynamic interactions between the tumor plasma cells and the bone marrow microenvironment. And circulating tumor plasma cells has been found to be an independent prognostic factor across the spectrum of plasma cell neoplasms. Again, similar gating strategies, I'm not going there. The markers will be same, not very different. Again, we get these bright 38, 138 population, and we isolate these plasma cells, and we can see that there are 2 or 3 populations here. We get these 2 populations, 19 bright, 45 bright, most likely normal plasma cells, 19 dim and 45 dim, most likely abnormal plasma cells. And we look at the kappa lambda. Yes, so these are abnormal and normal plasma cells. So we have circulating plasma cells, circulating tumor plasma cells in the peripheral blood. And if you look at this panel carefully, what I want to show you is that the abnormal plasma cells are nicely 38 and 138 bright. But the normal circulating plasma cells, they have a lower expression of CD138. So this is something that we very commonly see in the low circulating plasma cells, normal plasma cells. They have a lower level of CD138 compared to the bone marrow. And there are multiple studies now which have shown the effect of circulating plasma cells. For example, one by Gonzalez et al. Had a cutoff of more than 5 plasma cell per microliter, which picks up a group of patients in the RISS2, which has poorer prognosis. Again, Han et al. Found that more than 0.1% clonal plasma cells with RISS3 fall into an ultra high risk group. A study from India by Tambar et al. Found that CTPCs, that is circulating tumor plasma cells, more than or equal to 0.01% was independently associated with poor PFS and OS. So basically, peripheral blood can be used for prognostication of multiple myeloma using the circulating tumor plasma cells. If you want to look at the good review on circulating tumor plasma cells, please go through this paper. We just published this here from our institute on the review of the circulating tumor plasma cells. Great. Finally, we come to the flow cytometry-based MRD assessment in multiple myeloma. So we know that the treatment, if you're achieving CR in myeloma, we have a better OS and PFS. However, not all patients in CR have a good prognosis. That is why in 2015, the International Myeloma Working Group introduced MRD to provide more accurate hematological response assessment. So now multiple studies have demonstrated that the prognostic role of MRD, I am not going to that. And MRD negativity is now an established criteria in all multiple myeloma clinical trials. But whether it has an impact on clinical decision making, that is not very clear yet. Again, multiple trials are going on this. So again, the strategy would remain the same. Not going to the details of it, just that the proportion of abnormal plasma cells will be much lower post-therapy. But what is more important, that there are multiple technical issues in flow cytometry-based MRD assessment. One is that you can see here that we have taken nearly 5.7 million events. So you have to take a lot of events to have a good sensitive MRD assay. For that, what you really need is the first pull. So you can't be doing an MRD assay and you take the first pull and make slides from it to look at the morphology. If you do that, the second pull, which will be given for flow cytometry, will be very, very diluted, and you will not get enough plasma cells in that. So if you want more than 5 million events, you will have to ensure that the first pull has to go for flow cytometric evaluation. So this is something that we have to tell all the residents and the clinicians who are doing the bone marrow for flow cytometry-based MRD in multiple myeloma and other disorders, that first pull has to go to the flow cytometry tube. Then you really need to have bulk lysis, a standardized bulk lysis technology to have all these events. You can't do a stain lyse wash technique, or you can't do a simple lyse stain wash technique. You have to do bulk lysis so that all the cells are lysed together and you can have all the WBCs that you can to assess the plasma cells. You really need a lot of cells, as we discussed, nearly 10 to the power 7 evaluable cells to get a sensitivity of 10 to the power -5 or more. We get around 5 to 6 million. So we have a sensitivity of around 10 to the power -4 in our lab. And you have to have at least 8 to 12 color assay, not less than that, to have a high sensitivity MRD assay. In addition to this, we have all other problems as well, like which kind of vial do we take it in? ADTA is what more preferred. Then labs which are taking in transported samples. If the transport is more than 48 hours, the CD38 really rapidly starts to go down, and you won't be able to get your plasma cells, and your MRD assay will show a very low number of plasma cells. You have to have a standardized flow cytometry panel, and you'll have to establish the lower limit of detection and the lower limit of quantification for your own lab. So what we understand here is the major issue in MRD assay is the standardization, right? So this was the International Myeloma Working Group consensus criteria in 2016, which gave the sustained MRD negative criteria, the flow MRD negative criteria. But what you see here is that they're mentioning NGF or NGS to do MRD, not usual multiparametric flow cytometry. So what is this? So the first paper on this came was published in Leukemia in the year 2017, which showed very nicely how next generation flow cytometry is better than others. And what is next generation flow cytometry? It is basically a validated and standardized MRD assay that has been validated by the Euroflow group. Here the sensitivity goes up to 10 to the power minus 5 to 10 to the power minus 6. The cell equation has to be more than or equal to 5 to 10 million events at least. There is a fixed antibody panel, so you can't move around your antibodies here. And there is also a very highly standardized sample processing. So standardization issue is sorted there. And even the data analysis is automated and multidimensional. So most centers in Europe are doing this NGF now. This is not practiced in many centers in India. And NGF versus NGS, a very important thing is that you have to have fresh samples for NGF, but the sensitivity is nearly as much as that of the NGS, right? So before we finish, let's take one case, important case, where we had a 60-year-old male, multiple myeloma on therapy for 6 months, and the bone marrow examination was done for a pre-transplant MRD assessment, and morphology showed 5% plasma cells. Now we did similar gating strategy. We did 2 continuous events, remove the doublets, took only the viable cells, and when we looked at the 38 versus 138 region, there were hardly any plasma cells here. So we are very surprised. We are getting 5% plasma cells. We should get some cells here. We have got a nice number of events. We have got nearly 5 million events. We should get some plasma cells here. But now we are wise that we get this kind of issues when the patient has received daratumumab. A lot of times we do not get the information that the patient has received daratumumab. So we put this single tube which has 38 and 138 and does not have the other markers which are CD38 sparing. So what do we do here? So we know that CD38 positive cells, very bright cells, are plasma cells in the bone marrow. But there are also other cells which express moderate amount of CD38, like monocytes, hematogones, normal myeloid blasts, etc. So if you give daratumumab to a patient, not just the plasma cells will go away, but even the other cells which have moderate CD38, like monocytes and hematogones, they will also have a reduced expression of CD38. So that is the strategy that we use. So in the CD45 as a side scatter plot, we know this is the area of monocytes. We gate these cells, we give them a pink color, and we put the quadrant and see where the normal expression of monocytes should be. So this is based on the normal expression of monocytes in normal patients. And most monocytes are above this range of CD38. And in this case, we are seeing that the CD38 of these monocytes is very, very low. This would tell us that CD38 is downregulated on monocytes and the patient is likely to be on daratumumab. Now, once we realize this, we put the separate tube which has CD319 for gating, and now we are getting the plasma cells here. We are putting the plasma cells and purifying them, and we are seeing that there are 2 populations. One is 27 bright and the other is 27 negative and 56 bright. We are giving them 2 colors. The one which is 56 bright, we are calling them abnormal plasma cells. The one which is 56 negative, we are calling them normal plasma cells. We are seeing that the normal plasma cells is dividing nicely into kappa and lambda, whereas the abnormal plasma cells are kappa restricted. So this patient has MRD positivity, which we would have missed if we had not looked at this and we had not put the daratumumab tube, which has CD319 as the CD38 sparing tubes. So it is very, very important to put this information whenever you're sending a sample for MRD assay that you have given the patient daratumumab or not. Otherwise, we might miss the looking at the MRD in these patients. I think with that, the time is up. This is my institute, PGI-MAR. You can see the beautiful Shivalik Hills here in the background. These are the wonderful people I work with. I really want to acknowledge Professor Manubdesh Singh Sasdeva, who I do flow cytometer with. He has been my teacher and mentor here. And I thank you for your patience.
Thank you, sir. Thank you very much for such an elusive explanation for both flow cytometry as well as MRD. And the PGI happens to be my alma mater as well. So it was like a nostalgia for me this session. And I think very important issues have been dealt, like the percentage of plasma cells that really questions. Many people have a doubt whether, because majority of the times when we do flow after doing bone marrow, it's about 3 to 4% of the plasma cells that come as clonal. And then the clinician mostly at times can have a bias whether it's histidemia or something like that, why it is a myeloma. So that, and very important issues like mentioning the history of daratumumab therapy as well is very important from a clinician's side to mention when a person sends for MRD. Now, that question still remains whether we can use MRD as well for clinical practice. So to further answer this, we will move to session 3, where I'm very sure Navjeet sir will be happy to answer during the session when the question for MRD are taken by us. So thank you, sir. Now we'll move to the session 3, where Dr. Sadamini will be presenting a very good and a complex case of multiple myeloma. And I welcome all our respected panelists, Professor Reena ma'am, Dr. Satrupa and Dr. Nakul. Welcome you all, and let's start the session. Dr. Sadamini, all over to you.
Thank you, Tushar, and thank you to AIO team for giving me the opportunity. Let's start.
Dr. Sadamini, if you could be just a bit louder. It's slightly muffled, the sound, but I think if you speak a bit louder, everyone will be able to hear.
Am I audible right now?
Yes, just
Okay. Definitely.
this much pitch is fine. Thank you.
Okay. Thank you. Good evening, everyone. I think after first discussion, it will be easy for me to go through the slides. So let's just start. Is my slides visible?
Yes, Dr. Sadamini, your slides are visible.
Okay. And I think all my panelists are also there, right? So let's just start with this. Therapeutic dilemmas in multiple myeloma. In the month of May, a 73-year-old male presented with acute complaints of low grade of fever for 5 months, loss of appetite, and a weight loss of 1 to 2 kg, which was not significant over a period of 4 months.
Dr. Sadamini, sorry to interrupt. If you could go to slideshow view, only your first slide is visible.
I'm in the slideshow view only. Is it moving right now?
No,
Only your name, that
the
title.
slideshow view on the down right, there will be 65%. Na? Besides that, there is a icon. Right? This slideshow.
If you can just start the slideshow, I think we can see.
Slideshow only. Is it visible right now?
No.
From your side, if you can move the slides.
Roshni, if you can share your screen. I think you are having a second copy of the PPT. If you can.
I think you might have to share your screen again and share the entire screen, not just the presentation. If you try that, that might help. Don't share the presentation separately, share the entire screen, and then it works sometimes.
Is it okay right now?
Yes.
Yes, just change the slide once. Can you move to page 2?
Is it moving?
Yes, perfect.
Perfect. Please go on.
Sorry for that. So, in the month of May, a 73-year-old male presented with a chief complaints of low grade of fever for 4 months, loss of appetite, and a weight loss of 1 to 2 kg, which was not significant over a period of 4 months, and generalized weakness for 4 months. On examination, he only had a temperature of 99.4 degree Fahrenheit with mild pallor. His performance score was 0 with a comorbidity of DHP. We did a routine investigation. We showed that his hemoglobin was 8.5, TLC count was 2000 with a neutrophil predominance and a platelet count of 18,000. And the other routine test showed that he has an ESR of 54, vitamin B12 was 153, and a liver function test shows a protein of 8.17 and an altered albumin globulin ratio. With the renal function test was normal, and urine routine was showing a proteinuria of 1 plus 1. So, Dr. Satrupa, can you answer how would you like to approach such case?
Yeah. Hi, Sodamini. Thank you for the case. Can you go back? So we have a 73-year-old male, and as we can see, we have anemia. The MCV is not mentioned. I would we should always correlate it with the MCV here and the retic count in any case of evaluation of anemia. We can also see that the patient has pancytopenia and the B12 is low. But the point to note here is that which will when we are seeing reports like this will be the elevated globulin. And with his 73-year-old, I would really besides this
I would also do an LDH. I would do a serum calcium. I would also go for a baseline serum protein electrophoresis. I would also go for a bone marrow evaluation, aspiration, biopsy. And if the patient had the patient, I don't think has any bony symptoms. If the patient had any bony symptoms, I would also go for an imaging. But for now, I would stop at doing a bone marrow evaluation and the other biochemical tests that are pending.
Yeah, definitely. We also did the same. As if vitamin B12 was on the lower side, we have started him on vitamin B12 supplement. Along with that, we have done a serum protein electrophoresis, which was suggestive of a monoclonal protein, uh, 2.5 gram percentage. So we also did a bone marrow, which was hypercellular for the age, and it also showed some lymphoid aggregates with the scattered plasma cells. This is the half hour view, which showed that few plasma cells. The plasma cell percentage was around 7 to 8%. We also did the IAC, which also showed that the lymphocytes were CD20 positive and they were polyclonal, whereas the plasma cells, they were also CD138 positive, but they were kappa restricted. For further confirmation also, we did run a flow cytometry. You can very well see that the plasma cells were kappa restricted monoclonal type, but whereas the lymphocytes were polyclonal, so in both the kappa and lambda. My next question will be to Dr. Nakul. Do you routinely do flow cytometry for all of your plasma cell neoplasm?
The thing about us is we don't have an in-house flow cytometry, so we depend mostly on IHCs and flow cytometry because of the time frame to export the samples. That is one of the issues. Otherwise, yes, the advantage of flow cytometry is like how Dr. Nabjit's lecture gave us a wide insight in case it is not a myeloma, if it is in a precursor stage, but also in cases of delineation of clonality, that will be very much helpful. That is the major advantage. That's it.
Yeah.
Mostly we go by IHCs, not much of a flow because of the logistical issues in my place right now.
Actually, we have an in-house flow cytometry also, so we did the both. And as I've already shown that with the help of those flow cytometry, we have found that the plasma cells were clonal, but not the lymphocytes. And these are some of the investigations which are being mentioned by the institution that has already been highlighted by Dr. Satrupa that we did at the baseline. Is there any diagnostic challenge you face during flow cytometry? Dr. Tina Nair, ma'am, if you can answer this question.
So at diagnosis, if your case is a little difficult, so there are many differentials when you look at it upfront. So definitely we would like to do a flow cytometry at diagnosis. But in a large majority of very frank myeloma patients, we do avoid it because unlike in other diseases where you need your baseline to look at your MRD in multiple myeloma, I think we can get away with the initial diagnostic flow cytometry. So we don't really do it for very frank looking multiple myelomas. And if you have an in-house lab and you have your SOPs in order, maybe we don't look at diagnostic challenges, but we just heard that if you have to send the samples far away, then you would have problems, and those also have to be addressed.
Yes, as sir has already mentioned that despite of the usefulness of the flow cytometry, it can only be used for the mentioning the clonality, not for the enumeration, because of the reasons already being explained by sir. We also did some immunoglobulin levels and the free kappa lambda light chain assays, which showed that the immunoglobulin IgG level was 31.4, with kappa restricted, it was 103. The kappa lambda ratio was 3.11, LDH was 742, calcium was within the normal range, creatinine is also on the normal range. We did also an imaging of by body PET scan, which showed that there was no lytic lesions. We also did the immunotyping. It was suggestive of monoclonal IgG kappa detected. So, as per the IMWG criteria, as whatever I have shown, with this my monoclonal protein level was less than 3 gram. There was an altered SFLC ratio, and on the bone marrow, we got the plasma cell percentage of around 8 to 9%, with no other end organs. The cytopenias with which we presented, there was also 153, and with the vitamin B12 supplement, the cytopenias has recovered. So we made a diagnosis of monoclonal gammopathy of undetermined significance, and we planned the patient for the hematinic supplement and to be observed and have a follow-up in every month. But after 8 months, he then again presented with generalized weakness. On examination, he only had mild pallor with all the vitals stable, and this time also his performance score was 0. These are the parameters on the long-term on the follow-up where he didn't have any kind of cytopenia. But in the month of September, he started to have, and again started to have the cytopenia. In the month of October, which was 8 months from the diagnosis, he had a hemoglobin of 9.7, PLC count of 1,000, platelet of 40 to 50,000, and a lymphocyte predominance. We again did the serum free light chain assay and the immunoglobulin levels. We showed that the M band is still at the level of 2.4. IgG level was 25.4. IgM was less than 0.21, but the kappa, which was initially 103, now has raised up to the 307. With the kappa lambda ratio, which was initially 3, now has raised up to 19.35. Again, this time also he didn't have any hypercalcemia. The creatinine also a normal ratio, and the PET scan didn't show any kind of lytic lesions. We did the bone marrow assimilation and biopsy, which was again hypercellular marrow for the age, but this plasma cell percentage, which was initially being at the level of 78%, has rise up to more than 60%, and they were all kappa restricted. We thought we might have, at the baseline diagnosis, we might have missed some high-risk cytogenetic abnormalities. So we repeated a FISH this time, which was negative for any kind of high-risk cytogenetic abnormality. So I think we made a diagnosis. This time we made a final diagnosis of MGUS being progressed to multiple myeloma with an RIS stage of stage 2, IgG kappa type with a PFS of 42 months. And in end organ, we only had anemia this time. And as we all know that the rate of progression from MGUS to SMM is 1% per year, and from SMM to multiple myeloma is 5 to 20% per year. So I would like to ask Leena Nair ma'am, with this much of history, do you think this was a case of high-risk MGUS or we have missed something?
So did you do the cytogenetics and FISH in the bone marrow upfront?
No, ma'am. At the baseline, actually, we had a vitamin B12 deficiency, and with that supplement, there was a recovery from the cytopenia. So we didn't do that. We thought it's a case of MGUS. And
So
this
I
time, when we
kind of agree with the way you have managed, because this is an elderly patient, though the lurking feeling from the beginning was, and since it's a presentation on myeloma, that this was end up in myeloma. In the clinical practice, what happens is we see a lot of elderly patients with lots of other deficiencies. And personally, I don't like to start treatment very early. I like to wait, watch them maybe 3 months, 6 months, and only if like your parameters are progressing at a time when I'm convinced that they need treatment, I start. I am much older. The younger people may be more inclined to start earlier, and so we can take their opinion. But I would do exactly the same. If I'm not convinced and the patient is stable, there's no real hurry to start treatment, considering that it is an indolent disease, and in the elderly, we still take it as an incurable disease.
Dr. Nakul or Dr. Satrupa, do you have any other opinion?
I agree with ma'am. Like I would follow up this patient, and then if there was something suggestive, like the patient again had anemia, his counts, his hemoglobin started dropping, and then only I would again reevaluate. Otherwise, I would just follow up and see how he was doing.
We can take an opinion for whether what would be the differentials from the bone marrow and whether flow would help. So, can we have an opinion from our expert?
Amjit sir, if you could.
So, ma'am, are you saying at baseline or at the moment now that the patient has progressed?
No, the discussion is whether we missed something or could we have done something more to understand that this was going to quickly progress into multiple myeloma. So,
Right.
this has a very low percentage of plasma cells. So, on flow, could it have helped us more to start determining that this was indeed a myeloma and not really an MGUS, which would move on to a myeloma so soon?
Right. So I would say not on flow probably, But at baseline, in our institute, we would probably have done a fish cytogenetic analysis and seen if there are any high risk cytogenetic abnormalities to begin with, and see if the risk of progression would be higher then or not. I think that would have
Yeah,
been the approach that
that
we've
was
taken.
one of the things we were thinking of, and considering that she's shown us a normal cytogenetics 6, 7 months down the line, we
Right.
presume that that one was also have been normal. So we were just thinking beyond the cytogenetics and fish, if you could have helped us if we were to do a flow at that time. From differential diagnosis point of view, not from myeloma point.
Differential diagnosis. Yes, no, I think while at baseline we would have assessed all the other parameters as well, right? While doing a flow cytometry, we do use only a limited panel. We have say a 10 color or 8 color panel flow cytometry where we are looking predominantly at the myeloma markers. But if we look carefully, we can also have a look at other lineages when we are looking at these markers. This set of markers, through this set of markers, we can also maybe look at the B cells, see if there are any abnormalities there. We can look at the myeloid lineage cells also and see if there are any abnormalities there. These might have given us some clue at baseline, maybe. But again, as we discussed, the prognostication using flow is not great and not really taken into account in most places.
Actually, at the base diagnosis from the bone marrow, it was given as an LPL base. Thinking of that only, we have run the flow cytometry and we evaluated the lymphocyte actually basically. So lymphocyte came to the polyclonal. Only
Yes.
abnormality was plasma cells, which was kappa restricted. So we have proven that's why we have taken it as an endoscopy.
Right, right.
So just to talk about high-risk MGUS, there are three scoring systems like Mayo 2005, Student 2014, and NCI 2019. Mayo 2005 actually consider IgG type, M protein being less than 1.5 and a normal SFLC ratio. Presence of all the three make it as a low risk, and presence of any two will make it as an intermediate risk, and absence of all the three will make it as a high risk. In our patient, the M protein at presentation was also 2.5 with an altered SFLC ratio. So thinking, we thought this can be a case of intermediate risk of MGUS, and we kept him on follow-up. And when there was a cytopenia, we immediately evaluated and started the treatment. So how do you like to approach such a case of multiple myeloma in your practice? Ma'am, can you answer this one? What's your approach actually?
So an elderly patient is somebody, like I already said, I would go slow. So no quadruplets, no financial toxicity. Of course, you need to discuss with them. Some of them will say, one person will say, do everything that is required. Otherwise, triplets is a good combination, keeping in mind the comorbidities and the frailty of this patient. I do like to reduce my steroids a little early on. Maybe after 6 cycles, I try to take away steroids so that they don't get too many infections beyond that. And keep a watch on bortezomib toxicity also. Most patients don't tolerate lenalidomide in the dose that we would like to give them, that is 25. Very few patients actually take 25. So I normally start with 10 milligrams, and if they tolerate, I go up to 15 milligrams. The minute they start getting skin allergies, I try to avoid. So for me, if I have to plan, it would be 3 drugs, VRD, with a discussion. If they are happy to have daratumumab and there's enough finances, then I guess even in elderly patients who are transplant ineligible, one can consider quadruplets.
What about if the patient is transplant eligible and after 4 cycles he is not ready to go under transplant? So you go for an early stem cell collection and you continue with the therapy. When he's ready with the logistic issues, then you go for the transplant.
So two or three things. One is we don't really collect stem cells and keep. That has not been our practice for the many logistic reasons that it is difficult. Secondly, gradually the fear of lenalidomide and not getting enough stem cells is actually fading away. The third is that we don't really use the kind of lenalidomide dose. So if you see the Indian abstracts on many of the occasions, they have looked at the yield of the stem cells after lenalidomide therapy versus others, and there's not too much difference. And the fourth reason is that we do have good mobilizers today. So yeah, we don't collect the stem cells. And the fifth reason in this patient maybe is already over 73. So we discuss upfront whether they can really think in terms of transplant, provided his biological age is not what he looks like. And in that case, after 4 cycles, I would consider not collect and keep.
What about Dr. Satrupa and Dr. Nakul?
I think ma'am has already summarized very concisely as what we do, and it is not very different. The patients that we see, affordability for DARA is a major issue. So my first line would be like a VRD based therapy, as ma'am has highlighted, and we again start with lower doses of lenalidomide and dexamethasone, and then go up. And this for 73 would be like mostly transplant ineligible, and we will take it as a transplant ineligible myeloma. DARA RD is also an option. So again, if someone, but those patients are very few in the setup like we work in. So if at all, then DARA RD would be the next option. And early stem cell transplant, no, so that again, as ma'am said, there are a lot of logistics involved in cryopreservation, the costs involved. And in our experience, also, even with patients who have taken 6 to 8 cycles, like 8 cycles of lenalidomide, they with Pleraxipher now, they do mobilize well. We have adequate collection. We do rarely, we encounter trouble. So that would be my thoughts about it.
Agreeing with the same. I think the approach to the treatment has been already taken by the Pooja ma'am. I'll quickly rush. So what about how do you plan the response assessment in such a cases after starting the therapy? I mean, do you routinely practice MRD assessment, Dr. Nakul?
MRD assessment is at one time point is actually not very approachable way. Means we actually have to have a MRD negativity and then follow it up with a subsequent documentation of a persistent MRD negativity. That is what I feel should be the way forward. At any one time point, not a this thing. And plus with MRD, I would prefer, usually with a DARA based treatment, I have tried to go for MRD and then descale the maintenance part at the time of maintenance post transplant mainly. But pre-transplant MRD I have not been following much. It's usually post transplant because of the finance issues at wherever I've been working up. Not a very aggressive MRD advocator because of the finance aspect as of now.
We are also, because of the finance and logistic issue, we are actually doing those who are transplant ineligible. I think after the induction we are doing, and for those who are transplant eligible, I think we are doing after 3 months of the post transplant. So these are some of the articles
Can we ask Reena ma'am about her approach, like her institute?
Yes, I think.
So, I have a disclaimer. I retired from TMC last month, so I am actually not associated. But yeah, for a long time I was there. So most of the MRD work that we have done was actually in a clinical trial. So exactly like the time points we just heard, we did it within the trial. Then we were looking at pomalidomide upfront in the management of the 3 drug combination. We don't really do MRD because we don't change our treatment modalities as of now till more clinical trials and more robust data is available to say that you can really actually de-escalate in MRD negative patients, and or you can stop the maintenance early in MRD negative patients. For patients who are going in for transplant, yes, as a part of the transplant mechanism, we do their MRD assessment. And I agree that MRD assessment single is not, it is sustained MRD assessments to be done if you actually have to utilize MRD as a mechanism of altering your treatments. But at the moment, most of our treatments are still the old protocol based. That means you take a decision on the risk stratification, and then the maintenance is planned according to the risk stratification, and we don't yet use so much of MRD. It's mainly the lab getting validated for it. So in some, let me say, in some protocols, we have put the MRD assessment basically to get an idea of what it is. We are not changing treatments as of now.
Yeah, well, like ma'am already said, yes, there are some of the articles which have been recently published in NEGM and Blood, which says that we should adapt MRD as a MRD based approach. And I think IMWG has already recommended to go for MRD negativity, which has been already taken up by Nagdeep sir. This MRD endpoint, because MRD negativity will give us a better PFS and OS. And this is one of the trials, which master trial, which says we have to go for an MRD based approach. Which is, I think, in a trial we have not yet incorporated in our protocols. I think with that, we are open to discussion. Thank you.
Thank you, Dr. Sodamini, for such a nice session and lots of data and good articles supporting the use of MRD as well, and a very complex case managed nicely. And so yes, the treatments, what we as ma'am and all our respected panelists have told, the decision is always a combined decision with the patient. We have to take care of the finances as much as we want to give the best treatment. At the end of the day, we cannot fight with the patient's affordability and what schemes are available, what insurances are available. So all these are as important as to deliver a good therapy. I thank all the panelists for such for giving their precious time to this platform and enriching everyone, all the attendees. Well, we have had around more than 80 attendees today, and I thank everyone from the bottom of my heart, and it was lovely to have their insights. Thank you to Dr. Pooja, Dr. Navjeet sir, Reena ma'am, Dr. Satrupa, Dr. Nakul, and Dr. Sadamni. Wonderful the inputs, and I hope we stay in touch and keep on sharing and learning together. And Reena ma'am, would you like to give some remarks before others give their remarks as well?
So I enjoyed. I have been out of practice for 1 month, so I really enjoyed the lectures. It was a good relearning, so to say. And yes, the case was interesting, and such cases always worry us. And mostly the intention is that start treatment. So I always like people who can hold on treatment and decide what it is, and then take the right course rather than be in a hurry to start treatment. So interesting case. And the first lecture was also very nice. It was very complete and a complete revision of whatever I have learned maybe over 40 years. So thank you very much.
Dr. Navjeet, if you would like to say something.
Thank you a lot, Tushar. This was a great experience for me as well. Being the only hematopathologist here amongst all these stalwart clinicians, I also enjoyed, and I always learn a lot in these settings. So great learning experience. I'm sure for everybody as well. Thank you. Thanks.
Sir, we assure you that we are totally dependent on what you say when it comes to management of majority of our cases. I don't think we can sustain without flow cytometry. Although myeloma has some limitation, but I don't think we can move a step ahead without it. Dr. Satrupa and Dr. Nakul, before we can conclude, if you could give your assessments.
Thank you, Dr. Tushar, for inviting. And it's always, small discussions, short discussion, focused topics I feel are more useful than broad discussions. And the talks were really good. And learning from others, their experience, what they are practicing is always useful. So thank you.
It was a nice discussion and always a treat to listen to Reena ma'am's insights. So once I saw ma'am's name, I was like, yes, I will also learn something today new.
Thank you, Dr. Nakul. Dr. Sadamni, your concluding remarks, then we will just close the session.
So Tushar and the IAIO team for giving me the opportunity. I was very worried to present this case because if ma'am would have said that I have missed something at the baseline, I would have rather better to die because I don't want any patient to get hampered because of some diagnostic issues from our side actually. So thank you, ma'am. Thank you very much for supporting me in managing that patient. Thank you. Thank you, everybody.
So it has been a great session. Thank you all the attendees for attending it and making it a memorable one. So multiple myeloma, we should be aware of it. We should be aware of all the, there's lots to come, lots of new therapies with the teclistamab and many other more with the CAR-Ts. So the bright future still awaits. And on that note, we'd like to end the session. A very good night to everyone and a Merry Christmas.